talk to you about not just ingestions, but non-ingestions that are part of medical toxicology. So I want this lecture to be interactive. A lot of these are case studies, and I think you'll learn much better if we talk about the topic and management as opposed to just listening to somebody lecture. So next slide. Can anybody identify these tablets? You might find them at parties.
And you can write this in the chat box. We're going to be using the chat box again for this lecture.
Okay, so what's the difference between, this is actually ecstasy. In the US, we also call things mollies. Does anyone know the difference between a molly and an ecstasy? So I'll give you some background. Ecstasy is the trade name, or the colloquial name for NDMA. Has anyone heard of NDMA? Which stands for methylene dioxymethamphetamine. It's a drug of abuse. It became famous in the late 90s for rave parties. It's a stimulant. So this is actually ecstasy. So if the product comes in a tablet or it's compounded, it's called ecstasy. However, if it's a powder, it's called molly. Molly actually is basically a slang for molecular. So that's the difference between a molly and ecstasy. Has anyone ever seen that or encountered that in at parties at all? No, that's probably too sheltered then. Next slide. How about this? Bath salts. Has anyone ever? Well, actually, I've never used a bath salt in a bath, but has anyone come across these preparations on the internet or at a store? No. So what are bath salts? So these aren't bath salts. Bath salts are typically salt preparations that you put in a bath, you bathe in them. Sometimes they give off effervescent feel, like you're in a hot spring, but they look like bath salts, but they're actually a drug of abuse. So they're basically adulterated. And these are a result of synthetic chemical production, what they call synthetic cathinones. So they're basically also stimulants. They're basically derived from a plant product called khat, K-H-A-T, which is a leaf that's found in East Africa. It's a mild stimulant. In Somalia, in Kenya, people chew these leaves. It gives them a little bit of a high, keeps them awake, kind of like how we use caffeine in the Western world. Next slide. How about this? Also known as spice, K2. So this is basically what they used to call herbal marijuana. And what is herbal marijuana? Anybody know? So these are actually synthetic cannabinoids. Basically, they were sold as plant preparations, thought to be all natural, safe. You could find them in stores. All these products are now banned, but in the early 2000s, they were still legal. But basically, a chemist basically took THC, modified it to form what we call synthetic cannabinoid, which basically has another stimulant, type of drug of abuse. Next slide. So I'm going to talk about things that we probably see in the emergency department where, toxicology is a pretty broad field. There's, occupational toxicology, there's acute care toxicology, there is chronic toxicology. I'm going to talk about things that we can see in the hospital, especially in the emergency department, where if you evaluate the patient, the time is of the essence. You really need to use your clinical skills. All these things we're going to talk about don't really require any laboratory testing. And if they did, it would take too long to come back. So I'm going to first talk about toxidromes. We'll talk about cardiac toxicants, and finally systemic toxicants. So next slide. So the 5 different toxidromes are anticholinergic, cholinergic, sympathomimetic, sedative-hypnotic, and opioid. Have you guys covered this in your medical training at all? I know you probably may not see it in the first years of medical school, but I think if we kind of approach patients in terms of looking for toxidromes, it makes it much easier in terms of how to manage them. Next slide. So this toxidrome goes by the mnemonic sludge, or what we call salivation, lacrimation, urination, defecation, gastric emptying, or dumbbells. So those patients will basically be basically wet. They're crying, they're urinating, they're vomiting, they're having diarrhea. What kind of toxidrome looks like that? Any thoughts? Can you hit the button for me? So this is cholinergic toxidrome. Anybody have any idea what types of products causes a cholinergic toxidrome? No? So next button. This would be organophosphate. So you think about nerve agents, right? VX, VX, scillaren, soman, terbinafine, or also we can find them in pesticides, rodenticides like malathion, parathion. Carpamates are also used as pesticide agents, but they're also used as medicinals such as physostigmine, pyridostigmine, neostigmine. You also have cholinergic plants and mushrooms that also have cholinergic properties. Does anyone know what type of cholinergic plant what type of plant has this kind of toxicant? This is one plant that I can remember is a plant that Socrates used to commit suicide. So muscarinic is a form of is a receptor type of cholinergic receptor, but it's not necessarily a plant. So an example of a cholinergic plant might be poison hemlock, but Socrates repeatedly committed suicide by drinking poison hemlock. Basically became he developed neuromuscular paralysis and then died. Also some poisonous mushrooms like clitocypy or anosopy. Next slide. Next button. So how do you treat these things? So you basically treat a cholinergic with an anticholinergic, which would be atropine, which has muscarinic effects, or you could also use pralidoxime. We call it 2-PAM in the United States, and that's probably reserved for agents or patients with more serious toxic exposures. Next slide. How about this one? Mad as a hatter, hot as a hair, blind gnat, red as a beet, dry as a bone, full as a flask. So the choices are anticholinergic, sympathomimetic, opioid, or sedative-hypnotic. Okay, so it's an anticholinergic. Anyone else? So the answer is yes, it's anticholinergic. Next, can you hit the next button, please? And any agents we call as antihistamines, anticholinergics, cyclic antidepressants, and then plant preparations like Jimson weed, for example, or other belladonna alkaloid-containing plant preparations. And how do you treat an anticholinergic patient? So the main issue for the anticholinergic patients is that they're the main clinical concern is very, very agitated. So basically you want to sedate them, or you can give them a cholinergic agent. That would be pralidoxime. Next button, please. Next. So Shelley still there? Has anyone ever used physostigmine to reverse, say, diphenhydramine or Benadryl overdose?
I have not gotten the chance to yet.
So, it's amazing. These patients, particularly kids, they're just wildly agitated. You just can't control them. And oftentimes, sedating them with a benzodiazepine is very ineffective. You just can't find the right dose. And if in the right situation, you give them, let's say, 1 milligram of physostigmine slow IV bolus, and within 5 minutes, they're back to normal again. And it's also pretty helpful because, in those kind of patients, particularly in pediatric patients, you don't really know if the wild agitation is due to an infectious disorder like an encephalitis or metabolic disorder. So then you start thinking about giving them antibiotics, doing a lumbar puncture. But by giving them physostigmine, you reverse the process, they're back to normal again. You basically made the diagnosis and you've ruled out other conditions, and they're basically cured. Next slide. How about this one? Fever, hypertension, tachycardia, agitation, mydriasis, dilated pupils, diaphoretic.
Yeah, there you go. I was like, you're getting answers now.
Wow. So why is, you put down 2 cholinergic or sympathomimetic, very good. How could you tell the difference? So amphetamines are basically a sympathomimetic. The 2 toxidromes, anticholinergic and sympathomimetic, are very similar. So this is a sympathomimetic mimetic toxidrome. Next. So that would be cocaine, amphetamines. We just have the bath salts we talked about, the MDMA, methamphetamines, or it could also be sedative hypnotic withdrawal. And what is the treatment for this? So basically, there is really no antidote. You want to cool them. So cooling, fluid resuscitation, and sedating them. And we tend to like to use IV benzodiazepines as sedative. You put the brain to sleep, the peripheral manifestations will also improve as well. So next slide. Oh, so this one, I probably put this out of order, but this is meiosis, respiratory depression, depressed mental status. So this, okay, what else?
This one everyone gets.
Huh? What'd you say?
This one everyone gets.
Okay, what else could this be though, potentially? It could also be it could be sedative as well, but respiratory depression probably gives it away. So next, please. So this is an opioid toxidrome. So we talk, the opioids are heroin, morphine, fentanyl, methadone. And what's the treatment? So okay, naloxone is our antidote, but if it's mild cases, it's just supportive care, oxygen, mechanical ventilation. How do you dose naloxone? Oh, someone said naltrexone. So naltrexone is an opioid antagonist, but for the purposes of treating an acutely overdosed patients, it's not a good thing. Anybody have any reason why? So naltrexone comes as a oral preparation. It's not a parenteral preparation. That's one problem. So it's hard to get a guy or a gal who's depressed mental status, respiratory depression to swallow a pill. And so that could be problematic and they may aspirate. But the main problem with naltrexone is that it's a long-acting opioid antagonist. So if the person is being reversed, they might be reversed for 24 hours. And so that could be a problem. If the person is an opioid dependent person, they may develop withdrawal. That means they're probably consigned to having withdrawal lasting at least 24 hours, which in some situations could be life-threatening. Next slide, please. So, I always hear on the medics call, oh, we think we have an altered mental status patient and they have pinpoint pupils. Can we give them naloxone? This study was done in California in the early 90s. They took 730 consecutive patients where the medics thought that the patient may have had an opioid overdose, and they basically, at their discretion, empirically gave them naloxone. And they looked at the clinical parameters retrospectively to see how good these signs were. If you look at it, probably the best specificity and sensitivity is probably respiratory depression. Pinpoint pupils weren't that great. So having pinpoint pupils is not necessarily, synonymous with an opioid overdose. Next slide. So this is how I like to treat opioid overdose patients. So if there's two types of patients that come in, there's one person who's overdosed on their opioid, whether or not it be heroin or methadone or even morphine or codeine. They just have respiratory depression. They're sleeping, but they're breathing on their own. Maybe they're a little hypoxic. In that case, you start with a low dose naloxone, because if you give too much naloxone, they will develop withdrawal, and that could be a problem. However, if they're apneic, they're not breathing at all, you give the full 2 milligram dose. So for the respiratory depressed patient, you start slowly, maybe 0.1 milligrams or 0.01 milligrams, and just keep doubling the dose. We're using naloxone in this case is less of a therapeutic treatment as more of a diagnostic treatment, because if they're not having substantial respiratory depression, there really is no harm to the patient. The patient will survive. You just have to wait for the opioid to be metabolized for them to wake up. However, if they're not breathing, then obviously that's an emergency. You need to act fast. You give them 2 milligrams of naloxone. Probably means that they took a large dose. So the issue of developing withdrawal is probably not a clinical concern. In a lot of cases, go back. A lot of cases, the patient may have taken multiple agents. Maybe they took heroin and an amphetamine, which we call a speedball. So it could be a bad thing to give them too much naloxone. So if they've taken, let's say, heroin and cocaine or heroin and amphetamine, you reverse the heroin in their system. Now they have unopposed cocaine. They develop severe agitation. Now you're having a silent patient. Now you have a severely agitated patient. That's not a good thing. Or I've had cases where patients had maybe an overdose of heroin. They fell down a flight of stairs. They may have broken their neck. Now they're at somnolence. You give them naloxone, if you get agitated, they're vomiting, they sit up. You've already, now you've lost their C-spine precautions. Could be problematic as well. If the person got a large dose of naloxone, maybe 10 milligrams, and there's no response, it probably means that they did not take an opioid. There is one exception, and that's carfentanil. Carfentanil is a synthetic opioid. It's been out in the literature in the last couple of years, especially in the United States, where it's being used as an adulterant for drugs of abuse. Carfentanil is a super strong opioid agonist. It's about 1,000 times more potent than, 1,000 times more potent than fentanyl, and 100,000 times more potent than naloxone. And that might be one agent where 10 milligrams of naloxone might not be sufficient. I'm not aware of any cases in the United States where someone got poisoned with carfentanil, so I don't know how much you would actually need. Any questions? Next slide. Okay, unconscious, unresponsive patient. Temperature is 36, which is normal. Blood pressure is normal. Heart rate's normal. Respiratory rate is normal. What toxidrome is this one? Any thoughts?
I want to answer.
Pardon me?
I want to answer.
You could answer that.
Date rape. Here's my hint. Date rape.
Well, that's not a good topic.
Hey, that's what they use for it.
Okay, well, that's sure. Date rape, it could be lots of things though. Date rape could be rohypnol, it could be GHB, it could be chlorohydrate. So
yeah.
Next slide.
Okay, there we go.
So this is the classic coma with preserved vital signs. So someone's unconscious with normal vital signs. That's the hallmark for a hypnotic toxidrome. Next. So that would be benzodiazepines, Ambien, etomidate, propofol, alcohol, SSRIs. Basically, yeah, that's a huge category. And what's the treatment? Supportive care. I guess for benzos, you could use flumazenil. It's a benzodiazepine antagonist. But I think for purposes of the emergency department, if they've overdosed on benzodiazepine, they're probably more likely to be benzodiazepine dependent. And so if you give them flumazenil, you really can't control the dosing like you can with naloxone. You could cause withdrawal. In the case of benzodiazepine withdrawal, it's much more serious than opioid withdrawal. Benzodiazepine withdrawal can cause seizures, status epilepticus. So most people would say in this setting, unless you've given the benzodiazepine yourself and you know the patient's history, there's probably the risk of giving flumazenil is probably more severe than the benefit, because really no one really dies from a typical sedative-hypnotic overdose. Next slide. So I think I missed one. Do we miss one? Okay. So so here are the exceptions. What causes seizures? GHB. Has anyone ever heard of chloral hydrate? I know in the 80s and 90s, it was very popular as for conscious sedation, particularly in pediatric patients, because you could just give them a rectal suppository or oral medication and they can get their procedure done. That one causes tachycardias. Barbiturates, alcohol can cause hypotension and respiratory depression. That's probably why we don't use barbiturates that much anymore as an anxiolytic, because benzodiazepines are much safer. And then some other ones like glutethimide also causes seizures. Next slide. So let's name the antidote. I think I missed one, and someone asked me, I missed the sympathomimetic overdose toxidrome. That's very similar to anticholinergic. In fact, it's very hard to tell. There are a couple things you can do to tell the difference between those two. Anticholinergic will have decreased breath sounds. The sympathomimetic will have, for the anticholinergic overdose, and the sympathomimetic both have dilated pupils. Theoretically, for a sympathomimetic overdose, if you shine light into their eyes, the pupil should constrict a little bit because you have basically stimulation of the pupillary dilators. However, if you shine light in a person with an anticholinergic toxidrome, when they have dilated pupils, there should not be any pupillary response because the pupillary constrictors are basically paralyzed by the anticholinergic. And then finally, the last way to differentiate is looking for evidence of secretions. So a person with anticholinergic toxidrome will be extremely dry, their mouth will be dry, they won't be sweating, whereas the sympathomimetic overdose patient will be diaphoretic, tons of secretions. However, there's one caveat. If I've had this happen before, if a person is wildly agitated, let's say they're in New York City and it's at 90 degrees outside, if it's summertime, they're agitated outside for a couple hours, they become profoundly volume depleted, and at that point they were actually dry as a bone. They're flushed. They may look just like an anticholinergic toxidrome. Okay. Any questions? So let's name the antidote for this one. Cyanide. We actually have two antidotes for that. Hydroxycobalamin, or the old one, which is the cyanide antidote kit. We call it the Lilly antidote kit. Has 3 parts. Good. Next one, methemoglobinemia. Anybody know that one? So this is kind of interesting. You have a toxidrome where the person comes in looking blue, and the antidote is actually blue. So it's kind of unique. Organophosphates. The sodium nitrite, sodium nitrite is the third component of the cyanide antidote kit. But I think most people, particularly outside the United States, prefer hydroxycobalamin pre-vitamin B12. So pralidoxime is the antidote for, or atropine for organophosphates, and I'll talk about that later. How about methanol and ethylene glycol?
Yeah, ethanol.
Okay, ethanol. Yeah, when I trained in the 90s, we didn't have the real antidote. We would use alcohol. Alcohol is a competitive substrate for alcohol dehydrogenase, and you have to go to the liquor store and you basically, can drink if they're an NG tube. That we used to do that all the time. Now we use fomepizole, which basically is a alcohol dehydrogenase antagonist. Next slide. Next one, acetaminophen. Yeah, good. And acetylcysteine. You guys are really smart. How about carbon monoxide? Well, this is kind of debatable, but I think most people in the United States would feel that if there's going to be a treatment, it should be this and this hyperbaric oxygen. At least in animal models, models are very, very convincing that it prevents the development of delayed neurologic sequelae. People studies probably a little less clear. How about diphenhydramine? So we talked about this in the toxidrome. So this person's an anticholinergic, so you want to give a cholinergic. So to reverse it, physostigmine would be the treatment. It's probably someone took a diphenhydramine overdose, you give physostigmine. Physostigmine should not be used for every type of anticholinergic toxicity. For example, if someone took a cyclic antidepressant, it's contraindicated. It's been associated with the development of asystole. Glyburide. Glyburide is a sulfonylurea. In therapeutic dosing, it does not cause hypoglycemia, but in overdose it could. So there's an antidote for that one. Anyone know? Great, octreotide.
There we go.
Wow. Basically inhibits the release of insulin, so it counteracts the effect of glyburide. How about tricyclic antidepressants? So I don't think we see too much of this anymore. This was very popular in the late 80s and early 90s because cyclic antidepressants were the antidepressants of choice. They've been supplanted by SSRIs. So this is kind of a great toxicology, so there's a lot of critical care, and the treatment for that would be sodium bicarbonate. Yep. Finally, how about some isoniazid and gyrometra? So these are hydrazines, which is basically the main component of rocket fuel. Isoniazid causes seizures, and since there's a high incidence of patients taking INH because of tuberculosis or maybe AIDS treatment, patients can come in with status epilepticus, and if it's an unknown patient, you give this antidote empirically if your first measure, such as Ativan, does not work. And that would be pyridoxine, vitamin B6. Okay. All right, next slide. So, do anybody watch this movie, Casino Royale? What poison nearly killed James Bond at the poker table? I think the original movie, they weren't playing poker, they were playing baccarat. But I guess, poker became really popular during the time this movie was made, so they were actually playing Texas Hold'em. Anybody know? Do you want to watch this movie? Next.
I felt really dumb that I didn't watch the movie after I saw the slide.
Come on, no one here is a James Bond fan. It was laced. This this poison was laced in vodka, martini, shaken, not stirred. You know?
Hey, my Bulgarians are really good at movies. Why are none of them answering? I don't know.
No one watches movies here, I guess. You guys study too much.
Too much studying. You guys need breaks.
Too much studying. Come on. So the answer is digitalis. Okay. All right. Bonus question. Next. How did he survive? He treated himself and he survived. You remember that part? I guess no one watched the movie. They wouldn't know.
I did not watch the movie.
All right. How do you kill him? He gives him IV lidocaine and defibrillation. Shelley, do you think that would work in real life?
No.
No. All right. It's Hollywood, right? No,
hey, it looks really good though on film. Come on, we gotta give them
really
that.
Good. He's a stud. So next slide. So this is foxglove. So foxglove is a digitalis purpurea, and it's called foxglove. They think it's because the flower looks like the glove of the fingers of a glove, maybe a fox hunting glove. And digitalis purpurea is a plant that we get. What do we get from it? Does anybody know? No, next I'll go back. We get digitoxin. So no one uses digitoxin anymore. So that's not where our digoxin comes from. It comes from the next plant. It's called the Grecian Foxglove. That's called Digitalis lanata. And this one is where digoxin comes from. And that's why the trade name for digoxin is Lanoxin, right? Lanoxin, that's because it's derived from the species lanata. Just fun trivia. Next slide. So you probably should have learned this in physiology. So cardiac glycosides or cardiac diuresis work by what? They block sodium ATPase pumps, right? So the mechanism of action is threefold. The first thing it does is it increases vagal tone. So that's why we give digoxin to treat our patients with rapid atrial fibrillation. It slows down the heart rate. But that's a different effect. But in terms of the monocyte effect, when you block the sodium ATPase pump, you increase the amount of intracellular sodium and you decrease the amount of intracellular potassium. That basically shifts the resting potential upward, and that results in increased automaticity. The other thing it does is that because you're increasing the amount of intracellular sodium, the body tries to remove the sodium by switching sodium with calcium, you end up getting increased intracellular calcium, and that's what increases your contractility, and that's why digoxin is used for treatment of congestive heart failure. Next slide. So what are the effects? I'm going to just talk about the cardiac effects. There's also GI effects and neurologic effects, and maybe ophthalmologic effects. So you get we call the scoop SC changes. You'll see some, even therapeutic doses, you'll see some scooping of the FC waves. We call that Salvador Dali's mustache. But in terms of toxic effects, you see increased vagal tone, you see bradycardia, high degree heart block, and you also see increased automaticity, PVCs, VTAC, bidirectional VTAC. Next slide. So in terms of toxic effects, you can see someone with block, you can see someone with ventricular tachycardia, but you're not going to see increased atrial tachycardia or sinus tachycardia, because that's not a sign of ditch poisoning. Next slide. So here's an example of Salvador Dali's mustache. The ST scoop changes. You'll see depressions of the ST wave. It looks kind of like the shape of his mustache. That's not always there, but it's commonly seen on patients taking digoxin. Next slide. So you'll see first degree block, second degree AV block, even third degree AV block. Those are potential effects of digoxin. Next slide. And then you get ventricular effects with PVCs, bigeminy, VTAC. Next slide. Bidirectional VTAC was thought to be, pathognomonic for digoxin or poisoning, but there are some exceptions. There's aconite poisoning also presents with that way. And there's also familial catecholamine polymorphic tachycardia, which also presents that way. But if you do see this, vast majority of times, ditch poisoning. Next slide. So you get atrial tachycardia block. Next slide. Or regularized AFib. So it's such severe AV block that you have a junctional rhythm and you have underlying atrial fibrillation. Next slide. So how do we treat ditch poisoning? We give them Digibind, or we call it Digifab as the newer one. And how does it work? Next slide. So you basically immunize sheep with the digoxin albumin complex. The sheep mount antibodies to this, this antigen, and you phlebotomize them, you take out their blood, and then you basically retrieve the antibody, the whole digoxin antibody, and then you use papain, you cleave it, and then they will use you the FAB fragments, and the FAB fragments is what you put in the vial to be administered. Next slide. So how good is it? So if you get the person in time, it's about over 90% effective. This is a study with 150 patients in 1990 of when they were first investigating Digibind for treatment of ditch poisoning. Next slide. So in the setting of digoxin poisoning, what electrical rhythms are indications for Digibind? So when do you give this antidote? Does anybody know? Well, the answer is any type of rhythm where the person is likely to die. So someone with ventricular ectopy or VTAC, they're at risk of degenerating to a more malignant rhythm, or somebody with a severe high degree AV block. So they're basically first degree AV block, or be a second degree Winkie block, they're going to respond to atropine, but a mobilus type 2, a complete heart block, they're not going to respond to atropine. That's an indication for Digibind. Next slide. What 2 treatments are contraindicated in the setting of ditch poisoning? So one of the treatments that's contraindicated is probably no longer true, but it's probably still a test question. The one's definitely still a contraindication. Shelly, do you know?
Yes, I'm giving a hint. Still.
Pardon me? So one of them,
I'm giving a hint.
Give it. Are you going to give a hint?
I give a hint.
Oh, okay, yeah. So this one, if you give it, it causes stone heart. Basically, what happens is that the heart has a systolic contraction and never relaxes. And the person dies of a sudden cardiac arrest. And that's been shown in animal models, but I think that in humans, maybe 1 or 2 case reports at best that they've described that. But I think that a lot of people have probably given this medication empirically without knowing it was a ditch poison patient. And I think that you would have seen a lot more fatalities. So the first one is
I actually listened to you, so I actually know.
Okay. So the first one is IV calcium. So if you were thinking about someone who say overdose and they're severely bradycardic, you don't know if it's like digoxin, calcium channel blocker, or beta blocker, you probably not going to, you shouldn't draw out the IV calcium first. I want to try other things. Okay. And the second one is, what's the second treatment? Transvenous pacing. So back in the old days, when people were dying from digoxin overdose, there was no antidote. They tried to pace these people, basically caused, death. And I guess the feeling is that, the myocardium is very, very sensitized, is very irritable. Putting a pacer wire, basically, with an electrical shock near the heart will cause the heart to go into a malignant arrhythmia. As a counterpoint, transcutaneous pacing is not thought to be a problem with these patients. Next slide. So we talked about digoxin. It's kind of interesting that, you think digoxin is a plant preparation, but, cardioactive steroids are actually present in every organism, both animals and plants, including humans. Next slide. So the cardinalized is a class of, we saw cardioactive steroids are found in plants like digoxin, digitoxin, oleandrin, for example. And the buflid are the type of cardioactive steroids that are found in animals or mammals, particularly. And the only difference between these 2 structures is the pyral ring. The cardinalized is a 5-member ring, and the bufadiline is a 6-member ring. That's the only difference. Next slide. So there are lots of plants that contain cardioglycosides or cardioactive steroids. What's oleander? Oleander causes oleandrin. You probably, I don't know, you read about now and then that people mistakenly eat this plant or whatever and they die, or people have been poisoned by people with these plants. Probably most of these are myths. I think there was a famous book that was written talking about oleander using to kill somebody. So you might have heard of that. Lily of the Valley is another one, and then dog bait. Next slide. So name the plant and the name of the person holding the bouquet. This is a very famous person. And the hint is if you look at the ring, it might give you a clue. Well, that was Princess Diana's ring. That's right. So this is Kate Middleton. And what is What is the plant? Well, if you looked at the last slide, you would have seen it. This is Kate, next slide. So this is Kate Middleton, and when she got married, her bouquet was a bouquet of lily of the valley flowers. All right, this trivia. So then the other plants, this is Strophanthus. Strophanthus is a plant that we get wobbling from, and is also the glycoside is also used to make combi arrow poison. So if you're a Swahili warrior, you poison your tip of your spear with extract of this plant. Milkweed, next. And then back in the 50s, we always, this is no longer used now, but this was a very popular rodenticide. If you kill a rat by poisoning with like a ditch toxic agent, they would just vomit, they would die of a cardiac death, and they don't really develop any resistance to it. And the reason why this is so effective is because rats or all rodents are anatomically unable to vomit. So if you and I took a huge cardiac glycoside overdose, one of the first things we would do would be we would vomit, uncontrollably. That would basically self-decontaminate ourselves, but rats can't do that. So I guess people thought it'd be safer. So if a rat can't vomit, it would die. But if a person took it, they would vomit. They probably may not die. But it didn't turn out to be as safe as people thought, so it was taken off the market. So the other thing we'll talk about are toads, and these are called psychedelic toads. This is the Colorado River toad, and do you know why these are so popular? At least the United States are popular, but I think maybe in Australia. I'm not sure about Europe. I don't think there are a lot of toads in Europe that have this thing. So
I don't like creepy crawly things, so I wouldn't.
So these toads have secrete a venom from the parotid gland. Okay, and the reason why they're popular is that a lot of these toads have secreted LSD-like compound in their parotid gland venom. And so that's why people would lick these toads or harvest these toads. But some toads, next slide. Some toads actually have, a cardiac steroid, bufadienolide in their venom too. And that can cause confusion and it can cause death. Next slide. So, I think it's kind of popular in the central part of the city, central part of our country or the West Coast. You try to harvest these toads and get high, but I don't see that happening too often anymore. Next slide. And in Asia, this toad, Bufo gargarizans, the venom has been used to treat people with congestive heart failure as an herbal remedy for centuries now. So, but I'd like to point out in 1995, we actually had an outbreak of people dying from this. Next slide. So they would go to these herbal stores or they would go to these sex shops and they would buy this black thing. It was called rock hard. It's supposed to be an aphrodisiac because this venom also has like anesthetic properties. And I guess there are no instructions. It's not really FDA approved. So they would, instead of putting it on topically, they would eat it, thinking they would get high or something. Next slide. So they came with a similar presentation. They were having GI distress, they were in the waiting room. They were young, usually male adults, and they would die in the waiting room. But somehow somebody noted that before they died, the EKG was abnormal. They had high serum potassium, and somebody figured out this was actually a digoxin-like preparation, and they gave them digoxin, Digibind, and they survived. Next slide. So we recommend treatment for so this is Digibind is really for a plant-based cardiac steroids. So you give some cross reactivity for animal ones. You give them 10 vials of Digibind, and it can reverse. Next slide. All right, let's move on to another case. 45-year-old male ingests an unknown number of tablets of prescription medication. He is hypotensive. He is severely bradycardic. He has a normal respiratory rate. His pupils are myotic but reactive. He's lethargic and he responds to noxious stimuli. What's your thoughts?
Put it in the chat box.
So hypotensive bradycardic patients. So you're going to rule out like some pathomedic, right? Because they're usually the opposite, hypertensive tachycardic, right? You're not going to be opioids. So there's not a lot of drugs of abuse that cause hypotension and bradycardia. So it's probably a prescription medication. What prescription medication gives you bradycardia, for example? So for the purpose of this lecture, I'll give you, you need to think of beta blockers, calcium channel blockers, and then the third one is digoxin. What do you think, Shelly?
I wrote blockers.
These three. Huh?
I wrote blockers. I was trying to give them hints.
Okay. All right. Out of these three, which one is least likely then? Digoxin, beta blockers, or calcium channel blocker?
I've really mostly seen beta and calcium channel blockers, but that's because like most of our patients are on those drugs now.
Right.
Digoxin is not as popular.
Okay. Well, this is not digoxin for one reason. Probably mostly for one reason.
They're not having arrhythmias.
Well, remember, digoxin is an inotrope, right? So why is the person hypotensive? So generally, you're not going to get severe hypotension with digoxin.
Yeah.
So how about between beta blocker and calcium channel blocker? So let's just, well, I'm talking about calcium channel blocker. Obviously, you're not going to say the hydropyridines like like nifedipine. You're talking about like diltiazem, verapamil, those kind of calcium channel blockers. But how would you distinguish the beta blocker from the calcium channel blocker clinically?
Glucose.
Okay, well, I didn't give you the lab results.
I know.
We're going by clinical exam. You're an emergency physician. You can't wait for the labs to come back before you got to intervene, right?
Yeah.
So this is probably a beta blocker, and there's two reasons why. One, and I had to give it to you because it's in the slide. So one is their pupils. So beta blockers tend to cause myotic pupils. Calcium channel blockers don't have any effect on pupils.
Nice.
And secondly, beta blockers tend to cause ultramental CNS suppression, where calcium channel blockers don't usually do that. That's, the patient could be profoundly hypotensive on a calcium channel blocker, and they're wide awake and talking to you. And the theory is that calcium channel block, calcium is a necessary ingredient in NMDA receptor, so as an excitatory neurotransmitter, they tend to preserve their neurologic state. So what are our antidotes that we use to treat these overdoses?
Okay, people, put it in the chat. My hint to you, you're trying to block something. What can you do instead?
Okay, insulin's a good one. Anything else? Insulin's probably not going to be your first line, right? Because it takes a while to set up. You had to put them on an insulin infusion. You got to get the dextrose going as well. It's a little bit labor intensive. It takes some time. I mean, they may not require it unless it's severely poisoned. So what's the normal step for someone who's hypotensive? What do you give them? You give them fluids, okay. But then after fluids, then you have a couple things. So I'll open up the first one.
Yep.
So beta agonist. So the receptor is blocked potentially if it's a beta blocker, or the calcium channel is blocked. But if you give them more of the adrenergic agent, you may override that. So you want to use a beta agonist. In purposes of toxicology, you probably want to use a direct acting, not an indirect acting agent. So you probably want to use like a norepinephrine, maybe phenylephrine, but you would never want to use probably dopamine because dopamine is indirectly acting. Okay, so vasopressor. Next, so calcium would work. There's another one. Although if you're worried about digoxin, you probably want to avoid that. Glucagon. How does a glucagon work? So glucagon works by bypassing the receptor, increasing intracellular calcium by increasing the amount of cyclic AMP or second messenger. And thirdly, use phosphodiesterase inhibitors like milrinone and amrinone. And finally, you can, what the person said earlier, insulin is the last antidote. And if that doesn't work, I would always, especially in a young patient, I would always advocate getting cardiology or cardiac surgery involved. This person will probably be a good candidate for a balloon pump or bypass. Because think about it, they're developing cardiogenic shock from a pharmacologic agent. It's not like an old person with heart problems. If you can support them until they can metabolize their medication, their prognosis should be good. So this is how, if you look at the physiology, this is how it works in the myocyte. You have a beta agonist that blocks the receptor, or you have a calcium channel blocker that blocks the calcium channel. Well, all of that does is it basically breaks up that cascade. Our end product is trying to get contraction of the myocyte or some type of depolarization for a chronotropic effect. Next slide. So her antidote. So glucagon, that increases the adenylate cyclase, activates that. You're increasing cyclic AMP. Cyclic AMP is our second messenger that causes protein kinase to activate, increases the amount of intracellular calcium. Amrinone does the same thing. It inhibits the enzyme phosphodiesterase, so it prevents the breakups of cyclic AMP, so it still stays around in the cellular system. Calcium works by basically overriding the calcium channel. And then insulin is the last one. No one really knows how it works, but it's thought to basically increase intracellular calcium. The exact mechanism is unknown. Next slide. 24-year-old female, and just a known number of antidepressant medication, had one witness seizure prior to the medical arrival. She's hypotensive, severely tachycardic. She's got dilated pupils. She's unresponsive. Any thoughts? This is a very common overdose in the 80s and early 90s. We don't really see it anymore. It's probably because this medication is not that popular. But we always thought that if you got to treat this overdose in patients, you probably knew everything you know about toxicology back then. What do you think, Shali?
Is it a TCA overdose?
Well, it would be okay, maybe. Next slide. So this is EKG.
That's pretty wide complex there.
So there's a wide complex tachycardia. So what physiologic overdose causes a wide complex tachycardia?
I was still thinking TCA.
All right, anything that blocks the sodium channel will cause a widened QRS complex because it affects phase 0 depolarization. So this is a cyclic antidepressant, and it was very interesting. It would be basically a progression that you would see. The person would take the overdose. If it was really severe, they would seize in the field. If not, there would be a delay. They would seize, and then they develop their complications, which would be cardiac dysrhythmias, hypotension. And if you get to them fast enough, they would die. So what are the toxic effects? So keep going. So sodium channel blockade. That's what causes your cardiac dysrhythmia. It causes hypotension. Next. All of them are alpha blocker effects. So they were hypotensive. Actually, sometimes you think about it, they're anticholinergic as well, but sometimes they actually, because of the alpha blocker effects, they may have small pupils, not large pupils. And finally, altered mental status. Apparently, cyclic antidepressants inhibit the GABA receptor at the picrotoxin site, so they can cause seizures. Next slide. So any overdose, particularly when we're worried about cardiac toxic effect, we always do an ECG. And the reason why we do ECG is this: we're concerned about sodium channel blocker effects. What is the significance if the QRS is greater than 100 milliseconds and 160 milliseconds? Anybody know?
How much bicarb you gotta give?
Nope. So it gives you a prognosis of their or estimated risk of toxicity. So the wider the complex, the more sodium channel blocker effect is going on. So this is a famous study done in the New England Journal of Medicine in the mid-80s in Boston City Hospital. If you had a QRS greater than 100 milliseconds, 2.5 boxes, there's a 33% chance of seizures. It was greater than 160 milliseconds, or was it 4 boxes? There was a 50% risk of what they call cardiac dysrhythmia, ventricular tachycardia. And that EKG I showed you was by 4 or 5 boxes, so definitely was greater than 160 milliseconds. Really, for overdoses, we really just care about the QRS complex. We don't really care about the QTC too much. If the QRS is prolonged, the QTC will go on, but we're really looking for sodium channel effects. And if it's wide, that's an indication for treatment of giving sodium bicarb. Next slide. So IV access is established. You get 20 milliliters per kilogram of IV fluid normal saline. The patient's still hypotensive. Now obviously, in the case of ACLS, let's look at the algorithm. What happens if you look at the algorithm? Next slide. So the patient is unstable. If they're unstable, you give them, what does it say, establish, I can't read this, rapid, basically it's cardioversion. Do you think cardioversion is going to work? Electrical cardioversion is going to work for a TC overdose? No. And then if they're stable, what does the algorithm tell you to do? It says cardioversion, procainamide, or amiodarone. What do you think? What is procainamide? What type of antiarrhythmic is that? Procainamide is basically a 1A, right? And what is tricyclic antidepressant? They're also 1A. You're basically giving a 1A for another 1A. You're going to worsen the toxicity by prolonging the sodium channel blockade, right? And then amiodarone is a class 3 antiarrhythmic, also not a good thing as well. So this is an example where ACLS guidelines do not work for all scenarios. Next slide. So we usually give sodium bicarb for this. Sodium bicarb works by basically antagonizing the effect on the sodium channel. You basically open up the channel. Also, if you alkalinize the blood, you're actually increasing the susceptibility of the channel to open up. So it works out both ways, by alkalinizing the blood as well as giving the extra sodium. And I like to do it for us. We usually like to give them maybe 1 milliequivalent per kilogram bolus, and then you start them on a continuous infusion. I usually recommend putting 3 amps or 50 milliliters of sodium bicarbonate in 1 liter D5W. That gives you a nice, you just run it twice maintenance. And then you basically, in these cases, when you start giving, you see the cure start to narrow. It's actually quite remarkable. And gives you a really good effect as to how well the patient's responding. What are other drugs with sodium channel blocker properties?
Kind of clicked early, so someone should see that answer.
Oh, so cocaine does that. Well, I'm figuring no one's answering. I'll just go faster. Next,
That's
cocaine. Some of the phenothiazines will do that. Mesaridine and tyrosine. Next, milorg and milorg carbamazepine, anti-epileptic, propoxyphene, which is a not commonly used opioid agonist, and then other class 1 antidepressants. Next slide. So this one, 40-year-old female found in the ED after attempted suicide with carbamazepine. Those are vital, pretty much normal. What do you expect her pulse oximeter reading will be?
Okay, med students, you should know this.
It's going to be high, normal, or low.
There's your choices, high, normal, low. Hopefully someone writes in the chat box.
I think you would intuitively think, well, this is in impaired cellular respiration, the pulse ox should be low. Oh, no, people are saying low. But is it low? Next slide. It's normal. It just has to do with the light absorption. So when we use the pulse ox, either with our on the monitor in the hospital or your Apple Watch or whatever, you're shining light into the skin at 2 wavelengths, 660 nanometers and 940 nanometers, and you look at basically the absorption at those 2 lights and you get a ratio. And that's how you determine the O2 stat. For whatever reason, carboxyhemoglobin absorption as oxyhemoglobin. So that's why you're going to get a normal result. And so that's why if you're going to check carboxyhemoglobin level or measure it, you need to do it at 4 wavelengths. That's why that's why the normal pulse ox doesn't work. Okay, so what's the treatment? 100% oxygen. You want to look for an organ damage. We do an ECG. You want to do a good neurologic exam, looking for any type of neurologic disorders. And then lastly, you want to consider maybe sending into a hyperbaric unit. Next slide. I'll just skip that over. It's too complex. Next. 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 Okay, unconscious jeweler. So this is a hint. You gotta know what jewelers work with. Found unconscious inside his store. He's hypotensive, tachycardic. He's tachypnic, and his lactate's 15.
I always study this for the board exam, and then you ask me on a normal day, and I won't know.
So what type of agents would a jeweler be using? Well, I guess they do work with metals, but I'm not aware of gold or silver or platinum, or nickel causing any acute toxic effects. Okay, mercury. Well, mercury could, but it's not going to be this effect. I actually don't use mercury, but mercury wouldn't be that quickly in effect. Lead takes a bit of time. So this is something that's really, really fast, right? He was in a store, now he's unconscious, and he's having metabolic derangements. So the answer is cyanide. So cyanide is used for electroplating. So to basically get the metal to bind to each other. So how do you treat that? The main clue about this case is the reason why it's cyanide is the person has a severe acidosis, they have a severe lactic acidosis. If you have a lactate greater than 10 in an overdose situation, think of cyanide. You also, same thing with fire victims. If you have a fire victim and their lactate's greater than 10, it's not only think about carbon monoxide, but also think about cyanide. We have 2 antidote kits, the cyanide antidote kit, which is called the Lilly kit, and now we have hydroxycobalamin. At least in our hospital, we still use Lilly. I don't think we had the hydroxycobalamin. Next slide. So basically what it does is hydroxycobalamin binds to cyanide and you form B12. And it probably, I think, is more effective than our Lilly kit, but and it's definitely more safe. But the availability for us in our area is not that common. What it does, but vitamin B12 is a water-soluble vitamin. It's got a reddish color. It gets excreted in the urine. Next slide. So cyanide is found in mining, electroplaning, fires. It's also found in history. So does anyone know what Zyklon B is? You're a history buff. Zyklon B was a pesticide in the 1930s, and basically the Nazis used it to kill their concentration prisoners. By you add water to it, forms hydrogen cyanide gas. How about, you heard about Jonestown, 1978? There's a cult called the the People's Temple, Jim Jones. Anybody remember that story? So he basically poisoned all his followers in Guyana by having them drink, we call it Kool-Aid. So it's called drinking the Kool-Aid, but it wasn't Kool-Aid. I think it was a power drink with potassium cyanide. I think about over 1,000 people died. In the United States in the 1980s, we don't know who, basically tampered with Tylenol preparations. We had an outbreak of cyanide poisoning in the Chicago area. And what they did was, at the time, they used to sell Tylenol in not only capsules, but pre-made capsules, but they had the powder in those gelatin capsules. So someone just took out the Tylenol and put cyanide. So now they don't sell that type of preparation anymore. And finally, in the 1990s, the Japanese cult leader of Sergio, poisoned a judge with cyanide. Next slide. So there are 3 parts to the antidote kit. First one is amyl nitrite, second one is sodium nitrite, and third is sodium thiosulfate. We don't really use amyl nitrite in the hospital setting. It's really a pre-hospital setting. These are little pearls. You break them and you put them over the person's nose or a bag valve mask, and they inhale it. You can get them to like a 5% methemoglobin level. We probably just use the sodium nitrite and the sodium thiosulfate. Next slide. So if the jeweler was found in a fire, how would the management be different? This is probably more esoteric. You only give the thiosulfate because if they have concomitant carbon monoxide poisoning, if you induce the methemoglobinemia, you actually decrease their oxygen capacity even more. They develop more hypoxia. In that case, you just do the thiosulfate only. A lot of people think that for the cyanide kit, the sodium thiosulfate is probably the most important of the 3 antidotes. So this is how it works. You want to induce a methemoglobinemia, a cyanomethemoglobinemia, and then when the cyanomethemoglobinemia basically binds to the sodium thiosulfate, you form sodium thiocyanate, which is relatively non-toxic, and it gets excreted. So that's how the Lilly kit works. Okay, next slide. We have a 50 people incident in Newark, New Jersey. They're short of breath, they're vomiting, they're having seizures, they're sweaty, they have dilated pupils, they have secretions. What's the diagnosis? This is the hint. This is a movie. Anyone seen this movie before? This agent was found in a chain, what was it called? A chain of pearl configuration. Go back, no one knows. So this is basically an organophosphate. And I forgot the name of the movie. Do you know the name of the movie, Shelley?
I have no idea. I just know him from National Treasure.
Oh, it was the Rock. It was the Rock with Nicolas Cage, and this is VX gas. VX gas was stolen by these renegades, and they brought him to Alcatraz. Next slide. So how does this work? Next slide. So this is your normal synapse. Go back. So you have vesicles. In this case, we'll say it's acetylcholine. Acetylcholine is packaged in the vesicle and it's released into the synapse, right? And so the acetylcholine binds to either it's a muscarinic receptor or the receptor, and you get your in-organ effect. Now, acetylcholine is inactivated by a cholinesterase, and to acetate and choline that goes back to the presynaptic side, gets remade. So when organophosphate gets introduced into the body, it inactivates the cholinesterase. So the cholinesterase is no longer able to break down acetylcholine. You get accumulation of acetylcholine in the synapse. You get saturation of the receptors. Next slide. Oops, not so good. So really the physiologic effect depends on which receptors. If it's the nicotinic, you get the neuromuscular weakness. If it's muscarinic, you get the secretions, the bronchoria, and next slide. So there are different types. So the most potent is VX, has the highest lethality. Least toxic is malathion. Now malathion is still available in the United States. I know that New York City uses it all the time to get rid of mosquitoes. Next slide. So what are the treatments and how do they work? So we talked about this earlier. The first one is what? Atropine. Next slide. So basically that's a competitive agent with the with your acetylcholine. It's a competitive antagonist. It binds the receptor and doesn't do anything. Next slide. Or next. The pralidoxime is your antidote. So pralidoxime does is it regenerates the cholinesterase, takes the organophosphate off that enzyme, so the cholinesterase, the cholinesterase can basically break down your acetylcholine. Next slide. So this is how it works. So the green is the atropine. It's sitting on the receptor. It prevents the acetylcholine from getting there, so it can't do anything. And then basically the pralidoxime, next slide, takes the 2-PAM, 2-PAM takes off the organophosphate from the enzyme, so your enzyme is reactivated. Now there are certain agents that have what's called term called aging. They form irreversible bonds with the cholinesterase, and if it does that, then pralidoxime or 2-PAM would not be effective. But that's really, aging really only occurs in the nerve agents or high potency organophosphates. Most commercial preparations will not have aging occurring. So how do you treat it? So basically, it's not a weight-based treatment. It's based upon how much they took. So you basically start increasing the amount of atropine. I know when the Tokyo bombings, the hospitals were basically depleted of all their atropine. You can require grams of atropine under patient. Next slide. Atropine does not, because it's a muscarinic agent, it does not work on nicotinic receptors, so it would not have any effect on treating neuromuscular weakness. Pralidoxime, because it has no effect on the receptors, basically it's in the synapse, works on both nicotinic and muscarinic receptors. All right, so what are the indications? So anyone with neuromuscular weakness, you give pralidoxime, or anyone who has muscarinic symptoms that do not respond to normal doses of atropine, that's when you give pralidoxime. Okay, next slide. Any questions? No? Next slide. Okay, so which alcohol causes blindness? Okay, well, that's fast. So methanol.
Sorry.
Methanol is metabolized by alcohol dehydrogenase. Formic acid. Formic acid is a poison. It causes retinal toxicity. That's what causes blindness. Okay, next slide. Which one causes renal toxicity? Anybody have an idea? So it's ethylene glycol. Ethylene glycol is metabolized by alcohol dehydrogenase. It forms oxalic acid. Oxalic acid crystals basically obstruct the renal tubules, causes renal toxicity and renal failure. And what is the antidote? We talked about this earlier. The antidote is fomepizole, antizol. It blocks ADH. So basically the methanol stays as methanol. It never forms formic acid. You eventually renally eliminate the methanol and you have no problems. Same thing with the ethylene glycol. It's prevented from forming oxalic acid. Ethylene glycol is basically renally eliminated as well. And if you wanted to have a cheap high, you could basically drink alcohol and take fomepizole, and you'd probably be drunk for 24 hours. What is the toxic effect of isopropanol? So isopropanol is metabolized by alcohol dehydrogenase to acetone. You get intoxication. Acetone is pretty much non-toxic. You get the proverbial ketosis without acidosis. So normal pH, large ketones, severe intoxication, but no metabolic adverse effect. All right.